Medicine 3. Presenting to you, Mr. M, 51 years old, farmer from Jharkhand, presented with numbness and burning sensation of both hands and feet in 6 months and weakness of both upper and lower limb for the past 3 months. Elaborating the history, he started developing numbness and burning sensation of bilateral palms and later soles over 2 months, and the burning sensation ascended till knees bilaterally. After 3 months, he developed difficulty in picking objects with left hand. Initially, he noticed while bathing, he was unable to pick mug from the bathtub while taking bath, unable to pick peas with left hand, and unable to hold pen with left hand. But he was able to do overhead activities, like able to reach for objects, but he couldn't able to grasp those objects which were placed little high above. So there was subsequently over the course of 3 months, he developed slipping of slippers while walking from both foot, initially in the right, followed by left foot. On walking a distance of 100 meters, the slipping happens for 2 to 3 times. He has to insert the chappal every time into his foot with the help of right hand. He couldn't able to insert only with the help of lower limbs. He also developed from squatting position, later required assistance to get up. He also developed difficulty in climbing stairs, difficulty in getting up from bed while awakening from sleep, and he has to turn one side with the help of hand as support and was able to sit up subsequently. Over the past 2 weeks, he started developing weakness use over the right hand as well. There was history of weight loss of 10 kg over 6 months, but he was able to feel hot and cold sensation while taking bath. He was able to feel pinprick sensation, able to walk without support. There was no bowel bladder disturbances, no history suggestive of cranial nerve involvement, and no history suggestive of cerebellar involvement. No history of twitching of muscle, no history of diurnal variation or fatigability. There was no history of difficulty in seeing or waxing and waning course of illness, and it was kind of progressive illness. There was no history of joint pain, rash, fever, or breathlessness. Past history, he didn't have any known comorbidities. There was history of Ayurvedic medicine intake for 4 months, stopped 2 months back, but he started taking Ayurvedic medicine for this illness. Ayurvedic medicine was not prior to this onset of illness. Personal history is a mixed diet, consumes non-veg. History of ethanol intake for 10 years, stopped 4 months back. There was no history of smoking, no history of behavior, and no prior blood transfusion. Family history, he is a married gentleman, had 2 kids. No history of similar illness in the family and no history of similar illness in the neighborhood and community. So moving to examination, he was conscious and oriented. His blood pressure was 120/70 mmHg and pulse rate of 80 per minute, which was regular. No pallor, icterus, cyanosis, lymphadenopathic clubbing. Palpating the ulnar nerve on the left side, which was thickened. Moving to central nervous system examination, his higher mental functions was normal. Cranial nerves, no abnormalities detected. Motor stem, bulk thinning of bilateral temporalis and bilateral vastus medialis and vastus lateralis, and wasting of dorsal interossei. More in the medial aspect, over 4th and 5th digital space. Tone was normal. Power, left hand grip was poor. Reflexes, 3+ reflexes in both pectorals and right biceps and left supinata. 2+ reflexes in knee and ankle. There was ill-sustained clonus, lasted for up to 4 to 5 contractions. Bilateral plantars were mute. There was no fasciculations noted during the time of examination. Sensory system, fine touch and temperature decreased in the left hand and bilateral foot till the level of ankle. Crude touch, vibration, joint position signs were normal. Cerebellar signs, meningeal signs were negative. Spinal and autonomic system, there was no postural drop in blood pressure. Rest of other systemic examinations were within normal limits. So summarizing the history, he is a 51-year-old male farmer from Jharkhand, presented with sensory symptoms over the extremities, followed by asymmetric distal predominant weakness. Examination revealed weak left hand grip, muscle wasting, exaggerated reflexes in the upper limb, decreased sensation over the extremities with few palpable thickened peripheral nerves.
So lower limb only pain and temperature was lost.
Yes, sir.
So there was no posterior column dysfunction.
No posterior column dysfunction. Yes, sir. No, sir. Fine touch was lost. And temperature sensation also lost till the level of ankle.
Fine touch. The cerebellar signs?
No, sir. His power in the left distal aspect was 3/5. That only hand. So we didn't do just right limb and all. No. So syndrome complex of he had features of upper motor neuron lesion with upper motor neuron symptoms plus lower motor neuron symptoms plus sensory involvement. With this, we localized to illness to the spinal cord. So here, initial differentials we considered were syringomyelia, motor neuron disease, and multiple sclerosis. So we proceeded with EMG-NCV as the first test with asymmetric sensory motor axonal polyneuropathy suggestive of mononeuritis multiplex. We did MRI spine with whole spine screening where C-spine showed no abnormal signal intensity or no features of syrinx and no compressive myelopathy. So with this mononeuritis multiplex, so now the differentials which we considered were vasculitis, connective tissue disorders, infiltrative disorders like amyloid or sarcoid, HIV, paraneoplastic syndrome, Hansen's disease, nutritional vitamin B12 deficiency, alcohol related, diabetes, hypothyroidism, and heavy metal toxicity. So moving on to the investigation, his initial blood parameters, routine blood parameters were within normal limits. There was no age reversal. HbA1c was 5.2, B12 levels were 1054, TSH was 1.23. ACE levels were normal, cortisol was 9.1, BBS was negative. ANA vasculitis workup was negative. So we did a heavy metal screen which showed slightly elevated levels of lead of 21.3. Skin smears we did which showed all are negative for AFB. So we also kept paraneoplastic syndrome as a differential. We did MRI brain which found to be normal. We did LP. LP was found to be in the normal study. So we went ahead with PET. PET also didn't give any tumors. There was only one metabolically inactive tiny nodule in the upper lobe of right lung, but it was rediscussed with nuclear medicine. It was post-infective, post-inflammatory. So what's next? How to proceed further? So we went ahead with nerve biopsy since the clinical examination showed thick and palpable ulnar nerves. And the EMG-NCV and this pattern of weakness was, it started with left upper limb, subsequently right lower limb, subsequently right left lower limb, and then to the right upper limb. So in the EMG-NCV, there was complete absence of conduction of signals from the right sural nerve. So we went ahead with biopsy of the left sural nerve, which showed partial conduction as well. So when we did nerve biopsy, that showed numerous beaded and intact acid-fast lepra bacilli, including several globi, which are suggestive of borderline lepromatous Hansen neuritis on sural nerve biopsy. So if it is EMG-NCV showing LMN kind of features and it's a leprosy, why the patient had hyperreflexia? So we went ahead with literature stages of peripheral neuritis when the case is supposed to be in the irritants in the peripheral nerve are lepra bacilli, and they being present all the time keep up the irritant even when the patient develops drop food like paralysis. So this Dr. R. Subramaniam from Government General Hospital Madras, he has published this paper in 1945 in Indian Medical Gazette, where he observed around 24 patients who developed, who presented with claw hand and bilateral draw foot and all. So that he noticed all cases had exaggerated reflexes. Not even a single case has absent or normal reflexes. So, and this postulated theory has come after observing people of 24 patients. So, additional examination findings where a patient had lateral madrosis. There was diffuse scaling noted on both buttocks. Nails showed hypopigmentation with subungual hyperkeratosis with terminal hypopigmentation. There was hypoesthesia over ichthyotic patches on both forearms, and right greater auricular nerve was visible and palpable. Edema noted in the left hand with erythema on the palm. So, with this hypoesthesia and ichthyotic patches on both forearm, we read its split skin smear biopsy from those ichthyotic patches, which showed borderline tuberculoid Hansen, with showing features of granuloma with multinucleated giant cell and Langerhans types of giant cell, features suggestive of tuberculoid Hansen. So the final diagnosis made was borderline tuberculoid Hansen disease in type 1 reaction, where he had features of neuritis. So further evaluation and management, we did pre-MDT workup, which showed negative HLA-B13, and however his G6PD was low, less than 2.1, and his DAPSone was not started. He was started on multibacillary drug therapy, and we have planned to continue for the course of 1 year. For type 1 reaction, he was started on prednisolone 50 mg, 1 mg per kg, plan to taper by 10 mg every month till 20 mg. We did counseling and rehabilitation. He was counseled regarding the disease and advised family screening for the same, and he wanted follow-up at local hospital. He was also given MCR chapel and advised food care to avoid injuries. So the learning points would be in a clinical examination, hyperreflexia can be present in a case of Hansen's without spinal cord involvement, and approach to Hansen's neuropathy. So here in this slide, we can see the symptoms suggestive of neuropathy, and we need to take complete history and physical examination, and nerve thickening, any skin lesion suggestive of leprosy, and sensory testing and motor examination. And we need to exclude other causes which we have listed out in our differentials, causes for peripheral neuropathy and nerve thickening. And we can proceed with split skin smear biopsy. If it is negative or if we are not getting healed, we can go with nerve biopsy, which is considered to be the gold standard. And nerve conduction studies can support our evidence, and high resolution ultrasound can be done. These are my references, and thanks to Medicine 3 consultant, which helped to make diagnosis, and thanks to neurology, and thanks to dermatology to make a complete holistic approach. Thank you.
I think with leprosy on the decline, actually in some parts of India, leprosy is on the rise. I think a very careful examination, I think you picked up the peripheral nerves. As soon as you presented, I thought this must be leprosy or amyloid. So whether a skin biopsy early on the onset of your evaluation may have reduced a lot of the investigations. Just a point.
We did one skin biopsy. We were unable to pick up those.
I thought skin smear.
Skin smear, we did.
Not a biopsy, no, initially?
No, yes, sir.
Whether you should have done the biopsy early rather than a smear.
Sure.
Any comments from?
You said temperature is preserved.
No, ma'am, temperature decreased, ma'am.
It was good to go through those differentials. You presented that some sort of dissociation of sensory findings. Any other questions? Okay, go on to the last case.